Time's up.
Okay. Hello, everyone. I'm Dr. Zhang from Taiwan, and today is my great honor to host this section. And so this section is the APSC Cloud Forum of Cardiovascular Disease Series. And today's topic is clinical guidance update in preventing cardiovascular adverse effects in targeted oncology therapy, diagnosis, and treatment. So first of all, actually, targeted oncology therapy is becoming the mainstream in multiple cancer treatment protocol. So our targeted adverse effects are also emerging to catch attention in our media fields, particularly cardiology. Multiple widely applicable targeted cancer therapies, including trastuzumab-induced cardiac dysfunction, immune checkpoint inhibitors associated myocarditis, myositis, myasthenia gravis, Buchan's tyrosine kinase-related atrial fibrillation, hypertension, bleeding events, VEGF inhibitors-related hypertension, venous thromboembolism, and the landmark anthracycline-induced cardiotoxicity in therapy of many solid cancers will be heavily reviewed and presented in depth as to help recognition and well-planned management of cardio-oncology complications for our modern cardiologists. So I'm Dr. Chang from Taiwan, and so today I have my wonderful co-chair and this Christopher Koo from Singapore. So today we're going to have 5 wonderful speakers. And first of all, I'm going to go through the disclaimer. This content of the webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinars are those of the faculty members and do not necessarily present those of the APSC. Another housekeeping things is the live stream content of the webinar will be made available via APSC Cloud, APSC Facebook, and the YouTube page. So today we're going to have 5 wonderful speakers, and each section is about 20 minutes, followed by 5 minutes Q&A. So let's get started. And first of all, I introduce the first speaker, Dr. Melty Adriana from Indonesia. And she's the Faculty of Medicine in University Airlangga in Indonesia. Her topic today is prevention of anthracycline-induced cardiotoxicity by ACI-ARB and possibly SGLT2 inhibitor about the current perspective. So please welcome Irana, please.
Yeah. Thank you, distinguished chairperson, respected colleagues, and ladies and gentlemen. Good morning. It's a great honor to be a part of this Asia Pacific Forum. My name is Dr. Melty Ardiana. I'm cardiologist and preventive cardiovascular consultant from Indonesia. And I have prepared and recorded my presentation, and my pleasure to share it with all of the fellow today. Thank you for this opportunity.
There are things that we cannot hear, so could you make the volume up?
Oh, you can't hear it? Okay, let me try again. Apologize for this. Oh, sorry, I forgot.
Whether cardiotoxicity occurs, but how we prevent it precisely, safely, and sustainably. Today's presentation is structured into 5 parts. First, background and definition. We discuss about anthracycline-induced heart failure remains a major survivorship challenge. Although preventive therapy so promise, results have been inconsistent, often due to low-risk population and short follow-up. Current evidence highlight first, cardiotoxicity is individualized. One fit all strategy doesn't work. We must focus on high-risk patients. Second, we are moving beyond LVEF. Strain imaging and biomarker enable earlier detection, shifting us from reactive treatment to proactive prevention. And the third, prevention is evolving from simple hemodynamic support toward targeting biological mechanism of injury to enhance myocardial resilience. As we know, CTRCD, or cancer therapy-related cardiac dysfunction, is a broader and more modern concept than the older term chemotherapy-induced cardiomyopathy. It includes not only symptomatic heart failure, but also subclinical dysfunction and both reversible and irreversible injury. Traditionally, cardiotoxicity was defined as an absolute LVEF drop of more than 10% to below 50%. However, this definition missed early subclinical injury, which is why we now incorporate GLS and biomarker. According to the 2022 ESC Cardio Oncology Guideline, CTRCD is classified based on severity: mild, preserved LVEF with GLS decline or biomarker rise, and moderate LVEF 40 to 49% and severe LVEF below 40%. And for epidemiology and risk factor, antacid cardiotoxicity affect up to 30% patient, which is driven by cumulative dose, age, comorbid cardiovascular disease, genetic, and different in surveillance. Anthracycline cardiotoxicity is cumulative and progressive, accelerating beyond 300 to 400 milligram per square meter. Early events are common, but late dysfunction may appear decades later. By age 40, heart failure reach 4 to 5%, with up 30% showing subclinical LV dysfunction. Given the role of neurohormonal activation in remodeling, early RAS blockade offer a biological sound preventive approach, not merely treatment after dysfunction occur. Anthracycline cardiotoxicity is multifactorial, is a biologically complex. It involves oxidative stress, mitochondrial dysfunction, inflammation, and fibrosis. Because the injury is multifactorial, monotherapy may not be enough. Cost effective is an important consideration, particularly in the Asia Pacific region. Established generics such as ACE, RRB, and beta blocker are widely accessible, affordable, and supported by long-term clinical evidence. In contrast, newer agents like SGLT2 inhibitor offer mechanistic and early clinical promise, but at higher cost and with limited long-term cardio-oncology outcome data. So, the implementation in low and middle income country require consideration of budget constraints, infrastructure, and local relevant cost effectiveness data. In mechanism of anthracycline cardiotoxicity, anthracycline trigger oxidative stress, mitochondrial injury, and DNA damage. This pathway coverage on inflammation, apoptosis, and fibrosis, leading to irreversible remodeling. The biological complexity It explains why single pathway strategy may be insufficient. Okay, we talk about the RAS blockade. Anthracycline initiate oxidative stress and mitochondrial injury. Subsequent RAS activation amplify myocardial damage through pro-inflammatory and pro-fibrotic signaling. The pathological process progressed from apoptosis to adverse ventricular remodeling. RAS blockade interrupts this cascade, providing both a mechanistic and clinical rationale to preventive therapy. ACE inhibitor and IRB reduce wall stress, limit fibrosis, suppress inflammatory signaling, and improve endothelial function. By interrupting angiotensin II-mediated pathway, they help preserve myocardial structure and function during chemotherapy. In PRADA trial, show that candesartan modestly attenuated the decline in LVEF, achieving statistically significant but with a small absolute effect size. The cardioprotective signal was more consistent in subclinical parameter, particularly global longitudinal strain or GLS and marker of LV remodeling. And metoprolol, however, didn't demonstrate a significant effect. This finding suggests that RAS inhibition may influence early myocardial pathway, although the overall clinical impact appears limited. In Overcome study, early enalapril and carvedilol attenuated LVEF decline by about 3% in high-risk patients receiving intensive chemotherapy. This supports a risk-based early intervention strategy. However, this trial also highlights that benefit appear greatest in higher risk population, reinforcing the need for risk stratification. And in meta-analytic data suggests that ACE inhibitor attenuated early LVEF decline, particularly at 6 months, with good safety. However, long-term benefit remain less certain. Overall, this data support ACE inhibitor as a preventive strategy. In this meta-analytic data also suggests that ACE inhibitor and IRB attenuated early LVEF decline, particularly during active chemotherapy, with also good safety. However, long benefit appear more modest, and this data support RAS blockade as a reasonable and evidence-based preventive strategy. Okay. Let's talk about SGLT2 inhibitor in cardiotoxicity prevention. RAS blockade primarily target neurohormonal activation. In contrast, SGLT2 inhibitor may extend cardioprotection to mitochondrial dysfunction and inflammatory pathway. Early pilot trial and observational data suggest a potential preventive signal. However, the overall level evidence remains emerging. At present, SGLT2 inhibitors should be viewed as a complementary rather than foundational in cardiotoxicity prevention. In this picture, in observational data, SGLT2 inhibitor use was associated with lower rates of heart failure and arrhythmia without excess renal event. However, this result require confirmation in large randomized trial. In the Packard pilot study, show a lower incidence of subclinical CTRCD at 6 months with empagliflozin. LVEF LVEF preservation was modest and no difference were observed in clinical outcome. And these findings are preliminary, and we have require and this data require confirmation in larger randomized trial. Well, observational meta-analysis suggests a possible reduction in mortality with SGLT2 inhibitor. Heart failure outcome remain inconsistent and statistically uncertain. These findings are hypotheses generating rather than definitive. Only a randomized trial can clarify whether this signal reflect true cardioprotection. We have explored the underlying mechanism. We have examined the clinical evidence. The question now is, what should we do at bedside? This is a practical framework for decision making in anthracycline cardiotoxicity prevention. Cardiotoxicity prevention must be individual and risk driven. Start with baseline stratification, monitoring closely with GLS and biomarker, initiate RAS inhibition in high-risk patient, or first signaling of myocardial injury. And we consider SGLT2 inhibitor selectively, not routinely, not universally. The goal is not to treat everyone, but to protect those most likely to decline. Safely and implementation are important as efficacy. For ACE inhibitor or IRB, we start low and titrate gradually. We close monitoring of renal function and potassium. For SGLT2 inhibitor, volume status must be assessed carefully. Apply strict 6-day rule, withholding the drug during acute illness, fasting, or dehydration. This is for reduction of the risk euglycemic ketoacidosis. And we must synchronize cardiac monitoring with chemotherapy cycle. In preventive strategy, there is two conceptual. The first is universal prophylaxis is simple and may provide early protection. But as we know, it's risk overtreatment and higher cost, and also limited randomized outcome support. A risk-based strategy initiate therapy according to baseline risk and early injury signal, such as we use GLS decline or biomarker rise or high cumulative dose. This approach aligns with ASG guidance and allow precision without unnecessary polypharmacy. Risk-based prevention is built on 4 pillars. First, baseline imaging and GLS detect early injury. And then we use biomarker guided escalation, and we use ACE inhibitor and ARB attenuated decline in high-risk patient, and selective consideration of SGLT2 inhibitor. So prevention should be structured, not cumulative. ACE inhibitor are established and guideline supported. SGLT2 inhibitor are promising but still evolving. Our rule is balance innovation with evidence. Precision cardio-oncology is not about adopting every new therapy, but it is about integrating the right therapy in the right patient at the right time. Prevention should be risk-based. After baseline assessment, step 1, high-risk patients or those with early injury signal should start ACE inhibitor or IRB. And then SGLT2 inhibitor can be considered selectively, especially in patients with diabetes, CKD, or persistent dysfunction. This precision prevention, not universal prophylaxis. Okay, now finally we are in conclusion. Anthracycline cardiotoxicity is progressive and potentially preventable. ACE inhibitor remain the evidence-based foundation. SGLT2 inhibitors are promising but still evolving. Today, this stratified prevention represent best practice. The future of cardio-oncology lies not only in treating everyone the same, but in identifying who need protection, when to intervene, and how to tailor therapy based on biology and risk. Okay, thank you for your attention.
Thank you, Dr. Rana, for your wonderful presentation. It's very clear, especially like the algorithm and the summary that you made. And so just wondering that is any audience or like experts about cardio-oncologists here want to raise some questions? We still have 5 minutes. I'm wondering, Dr. Koo, do you want to add something?
I think it's a very comprehensive presentation, but actually I'm just curious, in your practice, it's always nice to hear how different countries practice because there's so much variation. A lot of your anthracycline patients are usually younger. I think the breast cancer female patients or your lymphoma patients. My question really is that, with all these medications, beta blockers, ACE, ARNIs, SGLTs, whatever we want, a lot of times we're not going to put all of them on them. And I'm just curious, is your strategy more for like putting them on a little bit of one and then a little bit on two, or are you planning to put more on one before you go on the other? Because I mean, there's so much variation in practice. So I'm just curious what you do usually.
Yeah. Okay. Thank you for your question. Of course, we are use 2022 guideline ESG that we have to put the baseline for the patient for the early detection for the cardiotoxicity with GLS or with biomarker, and then after that we can use the first line is ACE inhibitor and or IRB. For the beta blocker, we don't have to dual treatment. The first is ACE inhibitor and IRB. For the SGLT2 inhibitor, like my presentation, it is only for complement, yeah, because there is no RCT data, yeah, for the reduction of the cardiotoxicity. So the first line we use ACE inhibitor and or IRB. Thank you.
Actually, it's a difficult question because that most of the young women that had hypotension or blood pressure have no voice. It's kind of difficult to ask under like RAS blockers, these kind of drugs. Yeah, but I think it should be treated like individualized. Yeah, because we lack of evidence. So, follow-up question, I'm still wondering this: did you review any things about the like a GLP-1 or like a novel generation of MRAs? It's also play any kind of roles to treat anthracycline-induced cardiotoxicity? Like GLP-1, do you see anything evidence about that?
Yeah. GLP-1.
Yes.
There is no study for GLP-1, but look promising, for the anthracycline related CRTTD, but still there is no guideline for that. Yeah, we must wait for the RCT study, I think.
Okay, great. Thank you. Okay, so thank you so much. I think because of the time limited, so we are going to move to the next section. So the next speaker will be introduced by my co-chair, Dr. Koo, please.
Sure. Okay. I'm not sure we're having the slides for introduction, but nevertheless, I think our next speaker will be Dr. Kyohei Daigo, and he's from Keio University in Tokyo, Japan. And today he's going to talk mainly about trastuzumab. So we've talked about anthracyclines in the first study. I think now we're going to be talking about trastuzumab cardiomyopathy, another common cause for cardiomyopathy. And I think we look forward to listening and learning from you, Kyohei.
Thank you very much for the kind introduction. And my name is Kyohei Daigo from Keio University, Japan. And first of all, it is my great pleasure to speak today on this topic, risk stratification and management of trastuzumab-induced cardiac dysfunction, surveillance and treatment. So let me begin by outlining today's agenda. First, I will briefly introduce trastuzumab and discuss why this agent is highly relevant in contemporary clinical practice. Second, I will move on to risk stratification with particular emphasis on the HFA cost risk assessment. Third, we will discuss surveillance strategies and the management of trastuzumab-induced cardiotoxicity. And finally, I will briefly touch upon antibody-drug conjugates, or ADCs, an increasingly important class of agents in modern oncology. So now let's move on. As most of you may know, trastuzumab is a HER2-targeted therapy. HER2 stands for Human Epidermal Growth Factor Receptor 2, a transmembrane tyrosine kinase receptor involved in cell proliferation and survival signaling pathways. HER2-targeted therapy is indicated for patients with HER2-positive early-stage or metastatic breast cancer, as well as for HER2-positive metastatic gastric cancer. In breast cancer, HER2-positive disease accounts for approximately 15 to 25% of all breast cancer cases. And given the high global incidence of breast cancer, this translates into a substantial number of patients who are candidates for HER2-targeted therapy. And historically, HER2-positive breast cancer was associated with poor prognosis. However, the landscape changed dramatically after trastuzumab was approved by the US FDA in 1998 for metastatic breast cancer. Subsequently, a pivotal randomized clinical trial published in 2001 demonstrated that the addition of trastuzumab to chemotherapy significantly improved prognosis compared with chemotherapy alone in metastatic HER2-positive breast cancer. Since then, trastuzumab has remained a cornerstone of HER2-directed treatment. Before moving forward, I'd like to briefly summarize the current treatment strategy for early-stage HER2-positive breast cancer. Early breast cancer is generally classified into three major biological subtypes: hormone receptor positive, HER2 positive, and triple-negative breast cancer. Treatment strategies differ substantially according to these subtypes. In patients with HER2-positive early breast cancer, anti-HER2 therapy plays a central role in systemic treatment. In patients with small node-negative tumors, primary surgery is typically performed first, followed by advanced systemic therapy. For patients with larger tumors, neoadjuvant chemotherapy combined with trastuzumab is administered prior to surgery, and after that, anti-HER2 therapy is continued to complete a total duration of approximately 1 year. And in current practice, trastuzumab is administered sequentially after anthracycline therapy rather than concurrently in order to mitigate cardiac risk. Moreover, anthracycline-free regimens have increasingly been adapted in select patients to reduce cardiotoxicity while maintaining oncologic efficacy. So to conclude this introductory section, I'd like to briefly discuss the mechanisms underlying trastuzumab-induced cardiotoxicity. This figure illustrates the cardiomyocyte. Under physiological conditions, neuregulin-1 released from endothelial cells binds to HER4 which then dimerizes with HER2. This activates downstream pro-survival pathways, which are essential for maintaining myocardial integrity and adaptive stress responses. Trastuzumab blocks HER2 signaling in cardiomyocytes. As a result, neuregulin-mediated pro-survival signaling is impaired, reducing the heart's ability to respond to stress. Importantly, this effect becomes particularly relevant when cardiomyocytes are exposed to additional stressors, such as anthracycline-induced oxidative stress. In the contemporary era, the incidence of trastuzumab-related cardiotoxicity is relatively low. However, in the landmark trial in 2001, where trastuzumab was administered concurrently with anthracyclines, symptomatic heart failure occurred in about 16% of patients. Given this unexpectedly high incidence, treatment strategies were modified. With sequential administration following anthracycline therapy, the incidence of left ventricular dysfunction decreased substantially to approximately 7 to 10%, while symptomatic heart failure fell to around 2 to 4%. Furthermore, in anthracycline-free regimens, the risk is even lower. The incidence of asymptomatic left ventricular dysfunction occurs in roughly 2 to 4% of patients, and symptomatic heart failure is generally below 1%. These findings clearly demonstrate that prior or concurrent anthracycline exposure significantly increases the risk of trastuzumab-related cardiotoxicity. So now about risk stratification. And first of all, I'd like to ask you a simple question. Why do we need to stratify risk? The answer is straightforward: to optimize surveillance and management strategies. To better understand why risk stratification matters, let me show you a recent study. In a contemporary cohort of nearly 500 patients on trastuzumab, overall CTR-CD incidence was 8.7% and heart failure 1.6%. Patients classified as low risk by HFA-ICOS had very low rates of dysfunction and heart failure, while high-risk patients had substantially higher rates. And importantly, in low and medium-risk patients treated with trastuzumab without anthracyclines, no symptomatic heart failure events were reported. These findings support risk-guided surveillance instead of a one-size-fits-all approach. And perhaps the most widely used cardiovascular risk assessment in cardio-oncology today is the HFA-ICOS risk stratification framework. This framework incorporates multiple domains, including age, baseline cardiovascular risk factors, cardiac imaging parameters, and biomarkers, and cancer treatment-related factors. Based on these variables, patients are categorized into 4 risk groups, including low, moderate, high, or very high risk. In patients with HER2-positive breast cancer, the HFA-ICOS risk assessment has been externally validated in several clinical cohorts and has shown utility in stratifying cardiovascular risk before cancer therapy. For example, in a cohort of HER2-positive breast cancer patients, the HFA-ICOS score stratified patients into risk groups with progressively higher cardiotoxicity rates, and the score showed excellent negative predictive value. An editorial in the European Heart Journal highlighted that while ongoing refinement of the tool is needed, the HFA-ICOS score has reasonable good ability to identify patients at higher cardiovascular risk and guide management strategies. Although the HFA-ICOS framework is comprehensive and well validated, implementing it in daily clinical practice is not always straightforward. The score is relatively complex since it integrates multiple domains. Collecting and synthesizing all of this information can be time-consuming. To overcome these practical challenges and facilitate real-world implementation, Patrick and colleagues developed an interactive, web-based decision support tool to design to bring guideline-based recommendations directly to the point of care. This Cards on Copilot tool is freely accessible online and via this QR code. It allows clinicians to quickly estimate HFA-ICOS risk by simply selecting the cancer therapy agent, checking the relevant clinical variables, and submitting the information. The platform is also available in multiple languages, including several Asian languages, which further enhances its global applicability. This tool not only helps identify a patient's risk category, but also provides concise educational content regarding each cancer therapy class. In a pilot study involving internal medicine residents and cardiology fellows, use of this web-based application significantly improved knowledge of cardio-oncology guidelines. By leveraging digital tools that bring guideline recommendations directly into clinical workflow, we can enhance implementation and ultimately deliver high-quality, evidence-based care to our patients. So now coming back to the main theme and move on to surveillance and management. Once baseline cardiovascular risk has been determined, patients receiving HER2-targeted therapy should be monitored according to their risk category. The 2022 ESC guidelines recommend baseline transthoracic echocardiography for all patients prior to initiating HER2-targeted therapy, followed by surveillance imaging approximately every 3 months during treatment. In patients categorized as high or very high risk, more intensive monitoring should be considered. When cardiotoxicity is suspected or detected, a comprehensive cardiovascular evaluation should be performed. In cases of moderate or severe CTRCD, defined as heart failure regarding intensification of medical therapy or hospitalization, temporary interruption of trastuzumab is recommended. Interruption is also recommended in asymptomatic patients with a significant decline in FVEF, particularly when FVEF falls to less than 40%. After initiation and optimization of guideline-directed medical therapy, and once FVEF recovers to about 40%, and ideally to 50%, trastuzumab may be cautiously resumed with close cardiac monitoring. Since the 2022 EC guidelines were published, several important studies have investigated how best to apply surveillance in clinical practice. I will introduce two meaningful studies here. The first one was published in 2025, evaluated the feasibility and safety of reducing routine echocardiographic surveillance from every 3 months to every 6 months. This non-randomized clinical trial enrolled 190 patients with HER2-positive breast cancer, all treated with trastuzumab-based therapy without prior anthracyclines. Echocardiography was performed at baseline, 6 months, and 12 months as part of the study protocol. Over a median follow-up, about 17 months, no cardiac events, defined as symptomatic heart failure or cardiovascular death, were observed. Only one patient developed asymptomatic left ventricular dysfunction, which was managed with temporary treatment interruption and allowed resumption. Importantly, adherence to the reduced surveillance was high, demonstrating feasibility in real-world clinical settings. These findings suggest that reducing surveillance to every 6 months may be safe and feasible for low-risk patients receiving non-anthracycline HER2-targeted therapy, potentially reducing healthcare burden without compromising patient safety. Another important study, published in 2024, evaluated the prognosis after stopping cardioprotective therapy in patients who have recovered from CTRCD. In this cohort of 134 patients with improved LVEF, those who discontinued cardioprotective therapy experienced a significantly higher rate of adverse outcomes, including recurrent LV dysfunction or heart failure, hospitalization, compared with those who continue therapy. Importantly, patients with a baseline AVEF less than 45% at the time of CTLA-4 diagnosis were particularly vulnerable to worse outcomes after therapy withdrawal. These findings suggest that stopping heart failure treatment after upfront recovery may not be safe for all patients and should be approached cautiously, especially in those with more severe initial dysfunction. To further clarify the optimal long-term management, several prospective clinical trials are currently ongoing, including HeartSafe, SubMed-CTLA-4, and COP-RCT. The results of these trials will provide important evidence regarding surveillance strategies and safety of de-escalating cardioprotective therapy after recovery from CTLA-4. And as the final section of my lecture, I'd like to briefly touch on antibody-drug conjugates, or so-called ADCs. ADCs are an advanced form of targeted therapy that combines three key components: a monoclonal antibody, cytotoxic payload, and a linker that connects the two. This design allows for stronger anti-cancer activity while maintaining tumor specificity, thereby improving therapeutic efficacy compared with conventional HER2-targeted therapy. Representative examples include TDM1 and TDXD. Among ADCs, TDXD is emerging as a particularly promising agent. DESTINY-Breast3 demonstrated that TDXD significantly improved progression-free survival compared with TDM1 in patients with HER2-positive metastatic breast cancer. And DESTINY-Breast4 showed that TDXD improved both progression-free and overall survival in patients with HER2-low metastatic breast cancer. DESTINY-Breast12 further supported its effectiveness in patients with brain metastases. And DESTINY-Gastric1 demonstrated survival benefit in previously treated HER2-positive gastric cancer. As the use of TDXD expands rapidly across tumor types and HER2 expression levels, careful cardiovascular surveillance will become even more important in daily practice. There's still limited evidence regarding the cardiotoxicity of ADCs compared with traditional HER2-targeted therapies. A very recent meta-analysis published in 2025 evaluated cardiotoxic effects across HER2-targeted regimens, including TDXD and TDM1. In this pool analysis of over 9,000 patients from phase 3 trials, the incidence of AVEF decrease with TDXD was approximately 4.2%, similar to the rate seen with trastuzumab plus chemotherapy or trastuzumab with pertuzumab combinations. These results suggest that the cardiotoxic profile of TDXD appears comparable to conventional HER2-targeted therapy in terms of AVEF decline, but more research is needed to fully characterize cardiac risk associated with ADCs. So to summarize today's lecture, trastuzumab remains a cornerstone therapy, particularly in breast cancer, and has dramatically improved patient outcomes over the past 2 decades. However, it requires careful cardiovascular consideration. The HFA cost-risk assessment provides an effective method to stratify patients according to their risk of cardiotoxicity. By applying this tool, we can move toward more personalized surveillance strategies. And accordingly, risk-based monitoring of cardiotoxicity is recommended rather than a one-size-fits-all approach. Emerging evidence suggests that surveillance intensity may be safely tailored in select low-risk patients, although further studies are still warranted. At the same time, antibody-drug conjugates such as TDXD are being increasingly incorporated into routine oncology practice. The cardiovascular safety profile of these newer agents has not yet been fully characterized. Continued investigation will be essential as the use continues to grow. Thank you very much for your kind attention, and I'd like to sincerely thank the APSC Crowd Media team for this opportunity. And also, I'm deeply grateful to Dr. Shiraishi and Dr. Sawano for their mentorship. And I also feel privileged to be part of the CARD's own computational cardiology team, and sincerely appreciate their outstanding work. It has been a great honor to speak with colleagues from across Asia. Thank you.
Thank you, Kyohei. No, very nice slide. So I think the main thing I took away from this presentation was that I never knew about the app before. So it's a nice app because I personally hate doing the HFA cost scoring myself, even though in cardio oncology is part of something that we do, but I really hate doing it. And my main question to you, because I think it's useful with the app, and it's always interesting to know how different countries practice, because
Mhm.
I'm just curious with this app, have you targeted the oncologists? Because a lot of cardio oncology, the patients come to the cardio oncologist because the oncologist has referred. And they are the ones that
Yeah.
are sort of doing the screening, and they are the ones sort of figuring out whether problems are happening. And usually it's only when they detect that problems are happening, then they come to us. So I'm just curious, have you managed to attack the oncology crowd with, with your app so far?
Well, actually, I do not have my outpatient of cardio oncology, but I'm shadowing my mentor, my colleague, to see patients from oncology. So, in my hospital, many oncologists, including hematologists or uh, surgeons, uh, should tell us to monitor their heart function throughout the course of the cancer therapy. So I think, yeah, the combination between oncologists and cardiologists are important, especially in the each facility, each institutions.
Oh, that's great because I'm just curious. I don't suppose all oncologists refer every patient to you for surveillance, do they? I'm sure they probably have some filter. So I'm just curious
Not all
whether how
patients.
are they filtering at your end? Yeah.
Well, I'm not sure if how oncologists select patients to refer cardiologists. I don't know, but I think they usually stratify risk based on the past history or medication that they are taking. So I think oncologists also uh, have the ability to stratify risk of cardiovascular event, and I think in a hospital it is doing well.
Great. So I hope your app goes out to oncology because it's probably more useful from them as well. Right, no, but that's very nice. And actually, the other thing I wanted to ask as well, just again, I think a lot of these ATSD seminars are useful to know what happens around the region. So I don't know, let's say, I don't know if Dr. Sepalau, are you around, just in Thailand? Because the other issue I have with a lot of trastuzumab issues is the monitoring. I think as you've
Mhm.
rightly pointed out, Kyohei, three times at once, one echo every 3 months. It sounds nice, but in reality, a lot of times it's not going to happen, be it for cost, be it for logistics. And so that's why I'm just wondering, maybe perhaps in Thailand, like Dr. Settler, are you sticking with it once every 3 months, or now with some vague evidence showing once every 6 months, have you shifted towards a less frequent kind of monitoring in your patients? Yeah, just interested to hear you, Dr. Settler.
Well, yeah.
Yeah, I guess if she's not there, then Kyohei, I guess, have you shifted to a 3 month thing, or are you still doing 3 months, or are you doing 6 months now?
Yeah, in lower risk patients, as I have shown here, like no anthracycline use prior to the trastuzumab or no cardiovascular past history, we sometimes do echocardiography every 6 months, not 3 months. Or otherwise, we utilize BNP, natriuretic peptides measuring to follow patients instead of doing echocardiography.
Yeah, no, sounds like a great tip to, I think, rationalize things because, I mean, a lot of things happen in an ideal world, but I think a lot of times things are not very ideal in our practice. But yeah, those are great tips. All right, I think we can move on to the third speaker. Dr. Chan, what do you think?
Sure.
And
Okay,
thank you,
so
Kyohei. That was a great.
Thank you very
thank you so
much.
much. Okay. So actually, I'm going to move on and to introduce the first speaker. The first speaker is from Taiwan, and her name is Yi-Xin Hong, and she is a cardiologist in National Taiwan University Cancer Center. So today, her topic is about the management of immune checkpoint inhibitors. It's also not important issues associated with myocarditis and myositis and myasthenia gravis, biomarkers, imaging, and treatment. So please, Dr. Hong.
Yeah, thank you for your really kind introduction, and it is truly a pleasure to speak about this topic today. Immune checkpoint inhibitors have fundamentally transformed modern oncology. They have reshaped survival curves across multiple cancers and are now established as one of the central pillars of cancer treatment. So for those less familiar, immune checkpoint inhibitors are monoclonal antibodies that enhance anti-tumor immunity by blocking key regulatory pathways. So under normal physiological conditions, these checkpoints function as brakes, preventing excessive immune activation. So by inhibiting them, we release those brakes and restore T-cell-mediated immune response against cancer cells. ICI has improved survival in more than 20 cancer types and is now used not only in metastatic disease, but also in neoadjuvant and adjuvant settings. So the indications are expanded so rapidly that any summer slide becomes outdated as soon as it was published. However, we are also facing something new. By activating the immune system, we also trigger immune-related adverse events, complications that can affect nearly every major organ system. And among these toxicities, ICI-associated myocarditis remain the most feared. It may initially appear mild, but it can progress rapidly. And that is why this topic matters to all of us. So first of all, how common is ICI-related myocarditis and why is it a priority? ICI-associated myocarditis has long been described as rare but highly fatal. Reported incidence ranges from around 0.4 to 3%, depending on the population study and the definition applied. And the true incidence may still be underestimated because we have now combination regimens, dual ICI therapy, and broader indications. And these all may lead to higher real-world risk. But there's the key message. Even if myocarditis is not common, it is not rare enough to ignore because the population exposure is enormous. Over the past decade, ICI use has expanded dramatically. Up to 50% of newly diagnosed cancer patients may now be eligible for ICI therapy. So even if we assume a 1% incidence, given the scale of ICI exposure, that translates into thousands of cases per year in the US alone. And this is not limited to Western countries. Korea nationwide analysis nicely show annual ICI use increased from roughly 1,000 patients per year in 2017 to more than 50,000 patients per year in 2022, just within 5 years. So while myocarditis may not be common in percentage terms, the absolute burden is really high. And the next question is, what is the current consensus for making a formal diagnosis? The most widely accepted framework comes from the 2022 ESC Cardio-Oncology Guideline, which is supported by the 2021 ICOS consensus. So diagnosis can be established in two ways. The first is the pathophysiological diagnosis based on the endomyocardial biopsy, which remains the gold standard. But in real-world practice, most cases rely on clinical diagnosis, which is more practical and commonly used. So the clinical diagnosis requires new troponin elevation, plus either one major criteria, typically cardiac MR findings consistent with acute myocarditis, or two minor criteria, which may include symptoms such as fatigue, chest tightness, or shortness of breath, ventricular arrhythmia or new conduction disease, decline in systolic function, or overlapping immune-related adverse events such as hepatitis or myositis. The technical definition performs very well in terms of sensitivity, around 93%, which is important because we do not want to miss cases. However, the specificity is only moderate, around 70%. So there is emerging evidence suggesting that timing can improve diagnosis. If we incorporate the typical time to onset occurring within 3 months after ICI initiation as an additional minor criteria, the specificity may increase to over 83%. And this makes clinical sense because ICI-associated myocarditis most commonly occurs early after treatment begins. So in practice, diagnosis is also about understanding the clinical timeline. Now, in terms of biomarkers, what really matters? If there is one hallmark biomarker in ICI myocarditis, and it is troponin. So troponin elevation is present in about 94% of ICI myocarditis cases. It is the single most important signal. And beyond diagnosis, troponin also carries strong prognosis value. So one really nice study led by Joe Alisalam showed that the high sensitivity troponin T level greater than 32 times the upper limit of normal measured within 72 hours admission was strongly associated with 90-day major adverse cardiac events. And these tell us something very practical. Serial measurement during the first few days is important. It allows us to capture the peak value and to identify the high-risk patients. However, in real-world oncology practice, troponin is not always checked at the earliest stage, so we need to remain alert for all the red flags. And in fact, around 95% of patients with ICI myocarditis have at least 3 elevating biomarkers, including creatinine kinase, ST, LT, or LDH. And among these, creatinine kinase is the most useful and is strongly associated with ICI myocarditis. So if a patient receiving ICI therapy presents with some new heart failure symptoms or rising creatinine kinase, myocarditis should enter your differential diagnosis. So for biomarker part, troponin is essential, and as an alternative, creatinine kinase can be the early warning signal. Now, how about imaging? Can a normal LVEF rule out ICI myocarditis? And the answer is clearly no. About 55% of patients with ICI myocarditis present with preserved EF, and around 20 to 25% may even have a completely normal initial echo. So if we wait for EF to drop, we may miss the critical therapeutic window. There has been growing interest in global longitudinal strand, which appears to detect subtle myocardial dysfunction and may associate with outcomes. However, at this stage, global longitudinal strand may be overly sensitive and should not be used alone to establish or exclude the diagnosis. How about cardiac MR? Cardiac MR plays a central role. We typically apply the modified Lake-Lewis criteria, which were originally developed for non-ICI myocarditis, such as viral myocarditis. And in that context, cardiac MR performs very well with sensitivity up to 88%. However, ICI-related myocarditis behaves somehow differently. Less than half of patients fulfill both classic Lewis criteria. And more importantly, diagnosis still depends on timing. Cardiac MR findings may be subtle or even negative, especially early in the disease course. So if clinical suspicion remains high and imaging is inconclusive, endomyocardial biopsy remains the gold standard. And now we move on to the treatment. What is the first-line therapy? Steroids are the universal first-line treatment, but what matters even more is the timing. The concept of door to steroid time has emerged as one of the most actionable predictors we have. Initiating steroids within 24 hours after admission is associated with improved MACE-free survival. So in practice, early recognition and early treatment are important. And in terms of dosage, the ESC guideline recommend intravenous methylprednisolone at 500 to 1,000 milligrams daily for at least 3 days and followed by a gradual taper. The original evidence supporting high-dose therapy came from a retrospective study of 109 patients, which suggested that high-dose group had better outcomes. However, this was a relatively small study conducted several years ago. As our understanding of ICI myocarditis evolves, the role of so-called high-dose steroid is being questioned. The data just published last year from the International ICI myocarditis Registry retrospectively included more than 700 patients from 127 institutions, show that steroid dosage was not significantly associated with 30-day cardiac outcomes. And these naturally lead to the next questions. Does every patient truly need high-dose steroids? And this is one of the most debated issues in the field. Real-world data show that ICI myocarditis is not a uniform disease, it is heterogeneous and in a spectrum. About 23% of cases are classified as severe, while 77% are non-severe. and their outcomes are dramatically different. 1-year cardiovascular mortality is around 29% in severe cases, but closer to 5% in non-severe cases. So we need to ask, should these two groups be treated identically? In non-severe cases, such as asymptomatic patients with low-level troponin and preserved cardiac function, the high-dose steroids may compromise oncological outcomes and increase infection risk. In carefully selected mild cases, starting with a lower dose, such as 0.5 milligram per kilo per day, with very close monitoring may be a reasonable approach. But this decision should never be made in isolation. This is precisely where multidisciplinary discussion becomes essential. We must balance cardiac risk against oncological benefit and tailor treatment to the individual patients, rather than apply a one-size-fits-all strategy. Now, what about patients who are steroid refractory or hemodynamically unstable? These are among the most challenging cases we encounter. And in some patients, we also see the so-called triple M syndrome, the overlap of myocarditis, myositis, and myasthenia gravis. These patients are the very high risk with poorest outcome, and in-hospital mortality can reach 50 to 60%. So for patients who fail to improve with steroids or who present with cardiogenic shock, life-threatening arrhythmias, or with triple M syndrome, second-line immunosuppression becomes necessary. Available options include abatacept, JAK-STAT inhibitors such as ruxolitinib, infliximab, IVIG, plasmapheresis, MMF, and others. At our institution, we have successfully managed several cases using second-line strategies such as abatacept, plasmapheresis, and IVIG. However, it is important to understand that the evidence base remains limited, and much of our current practice is derived from registry and case series. Standardized treatment protocols for these fatal cases remains an urgent unmet need. And we are awaiting results from ongoing randomized control trials, which will hopefully provide more evidence on optimal strategies. Until then, management requires multidisciplinary coordination with oncologists, rheumatologists, neurologists, and critical care team, and also individualized decision-making. And finally, can we re-challenge ICIs after myocarditis? And is it safe? In general, restarting immune checkpoint inhibitors after the severe myocarditis is considered contraindicated given the high risk of recurrence and potentially fatal outcomes. However, clinical reality is often more complex. In selected cases where no effective alternative therapy exists, a carefully considered challenge may be an option, but this should only occur after thorough weighing the oncology benefit against the cardiovascular risk. Even in these carefully selected patients, close monitoring is essential, and this includes baseline cardiac assessment before a challenge, serial troponin measurements during early cycles, and very clear patient education about early warning symptoms. So patients must understand that prompt reporting of chest discomfort, dyspnea, or palpitation can be life-saving. So while our challenges it may be justified, provided that monitoring is intense. Now let's come back to our daily practice. Should every patient receiving ICI therapy undergo cardio-oncology assessment? And what surveillance strategy should we apply? This is a very common question from our oncology colleagues. According to the ESC guidelines, patients are divided into low-risk and high-risk groups. And high-risk groups include patients receiving dual ICI therapy, combination therapy with other cardiotoxic agents, history of prior immune-related adverse events, and pre-existing CTR-CD or cardiovascular disease. And there's one message from this flowchart that is simple and extremely important. Every patient should have a baseline troponin and EKG before starting ICI therapy. Why is this so important? Because we have all received that phone call. A patient is in their second or third cycle feeling cyclic fatigue, maybe some vague discomfort. Someone checks this high sensitivity troponin T and comes back mildly elevated, maybe in the 30s. And the question comes, it's above normal. What do we do now? And thankfully, somebody had the foresight to check troponin T at the baseline, and it was 26. So you can say, thanks for the call and have a great day. So that baseline value allows you to interpret the change in context. It prevents unnecessary panic, unnecessary survey, unnecessary admission, and potentially unnecessary interruption of ICI therapy. Now, what about routine on-treatment surveillance? And this remains controversial as well. So two important studies led by Professor Henzu from Center University suggested that serial troponin monitoring may allow earlier detection of myocarditis. However, troponin elevations can occur in about 11% of patients. Around 14% of symptomatic patients has ICI treatment delays due to abnormal troponin levels that were ultimately not attributed to myocarditis. So overscreening carries its own risk, especially in symptomatic patients, may cause unnecessary treatment interruption. So at this stage, we still need more data and experience to determine the optimal survival strategy. And for now, a balanced approach is key. Baseline testing for everyone, targeted monitoring for high-risk patients, and careful clinical interpretation for both early diagnosis of ICI myocarditis and for avoiding unnecessary interruption of ICI therapy. And finally, I would like to leave you with one broader perspective. Although ICI-associated myocarditis has become a well-recognized entity in the modern oncology era, it is likely only the tip of the iceberg. Emerging data suggested that immune checkpoint inhibitors may also accelerate atherosclerosis and increase long-term cardiovascular risk. So the story does not end with myocarditis. As more patients receive ICI therapy, as they live longer, we will encounter more chronic cardiovascular complications. And this means our role as cardiologists has also become partners in the long-term cardiovascular care of cancer patients. And that is why cardio-oncology is not just a niche field, it is becoming an essential part of modern cardiovascular medicine. So to conclude, immune checkpoint inhibitors have revolutionized cancer care, but they have also introduced a new kind of cardiovascular emergency. ICI-related myocarditis may be uncommon in percentage terms, but because ICIs are now so widely used, the absolute burden is high. In practical terms, always check a baseline troponin and EKG before initiating ICI therapy. That simple step can prevent enormous diagnosis confusion later. Also, suspect early, especially during the first 3 months and in high-risk patients. And remember, adult steroid time under 24 hours is one of the strongest predictors of outcome. And for patients who are steroid refractory or hemodynamically unstable, escalate to second-line immunosuppression in close collaboration with oncology and critical care teams. And finally, myocarditis is only part of the story. As more patients receive ICI and live longer, we will increasingly face long-term cardiovascular disease. So we are no longer only treating traditional cardiovascular disease, we're becoming long-term partners in the cardiovascular care of cancer patients and survivors. So thank you very much. I look forward to the discussion.
Thank you so much, Dr. Hong. This is a very nice and comprehensive review about the ICI-induced myocarditis. So actually, I have a few questions for you. And I think the first one, because you raised the importance about the troponin. But the study that you mentioned is about the complementary troponin. It's not high sensitive. So actually, this commonly used, like in my hospital, we use the high-sensitive troponin I and they use high-sensitive T. So is there any evidence about the high-sensitive troponins or what kind of draws of it or the other possible biomarkers for the following or like the surveillance? Thank you.
Yeah, it's a really nice question that often asked by cardio-oncology, and actually there's no like similar data reporting which troponin should we use, either troponin I or troponin T. So some studied to compare troponin T and troponin I, and some said that troponin is more sensitive and troponin I is more specific for myocarditis. But in practical terms, it depends on which tool you have in your institution. So for the Stanford group, they usually use troponin I, and for the ICI registry, they usually use troponin T. So now we don't have a uniform like data for that, and probably we need more study on that. So for now, it's based on what your center have, and so you use that biomarkers. Yeah.
Perfect. So the second question is about the clinical practice because actually so we know nowadays we have the cardiac mice and other more like handy tools to diagnose the ICI-induced myocarditis, but actually I think it's kind of dilemma to treat this patient with hydrosteroid. You mentioned about the one like an adult to steroid and within 24 hours. I truly agree with that. But sometimes the patient will possibly have an infection or the other possible complications that's kind of contradictory to the hydrosteroid like immunosuppressant. Just want to know your opinions or your experience about what kind of how to make the prompt decisions to treat. Sometimes cardiologists make it or like oncologists suggest it, and the other thing is about the challenge. Yes, because most of the time this patient only have like this less line of the treatment. Yeah, but the challenges. Do you have any experience about that? Thank you.
Yeah, thank you for the question. So first part of the questions, when do we initiate the steroids and how about the concern for the infection? And that is why we have the clinical diagnosis tools for that. If we fulfill some of the parameters or some of the criteria, we drop the patients to the ISA myocarditis. But also don't ever forget the timeline because ISA myocarditis usually happens at the early stage of the treatment. So this is first. And also we need to rule out the infection. So based on the patient history, there is always gray zone in cardiac oncology. So always have the history taking, always discussion with the oncologist so that we can make the best decision for the patient. And everything is about individualized. And for the second part, for the challenge, yes, for the challenge because some of the patients do not have other treatment for them. So if the previous myocarditis is just mild, I would discuss with the patient and also the oncologist to re-challenge. But during the challenge, I would have the echo, have the troponin, have the EKG at the baseline. And during the challenge, at every cycle, the patient will also check the troponin T and also to educate the patient about the red flag sign. So only in mild cases, and if the patient does not have other optimal treatment for their cancer, I would suggest re-challenge. Otherwise, the patient have to take some risk for that and need to discuss with oncologists. Yeah.
Okay, thank you so much. I'm wondering, is there any other questions from the audience? Okay. Okay, thank you so much, Dr. Hong. It's really nice talk. So if no more questions, we're going to move on the next sections. So I'm going to invite Dr. Ku, my co-chair, to introduce the next speaker. Thank you.
Thank you. So fourth talk for today. So we have Dr. Pontera Setalau from Mahidol University in Bangkok, Thailand. And she's going to be talking to us another targeted kind of cardio adverse event, and that's really about BTK toxicities. And so that's mainly about atrial fibrillation, hypertension, and bleeding events. So please, Dr. Setalau.
Thank you, Dr. Ku. Okay, okay, and today, okay, thank you, Dr. Ku. And today, I would like to present my topic that about the diagnosis and treatment of cardiovascular adverse event in bruton tyrosine kinase targeted therapy in the side effect of the atrial fibrillation, hypertension, and bleeding event. And for everyone that about the bruton tyrosine kinase inhibitor, the bruton tyrosine kinase has a role in BCR signaling in the B cell because that in the BCR signal have the very important enzyme in the B cell receptor signaling. It can use in the B cell survival and proliferation. So we use the BCR signal in the BTK receptor in the B cell in the advanced B cell lymphoma or in the CLL in the some hematologic malignancy. So when we use the bruton tyrosine kinase inhibitor at that the chemotherapy and the targeted in the B cell malignancy, because that when we block BTK, it is meaning that we shut down the B cell. So the BTK tyrosine or bruton tyrosine kinase inhibitor, that means that ibrutinib acalabrutinib, zanubrutinib, and tirabrutinib also block that the gene structure and in the BTK, and when we interaction with this, it can cause that stop B cell proliferation. And how about that the bruton tyrosine kinase inhibitor and cardiovascular toxicity? In the FDA approved that the small molecule inhibitor of the BTK, the ibrutinib is the first generation that is well known in the BTK inhibitor that can treat in the B cell lymphoma and the CLL. And the second generation acalabrutinib and zanubrutinib is also the irreversible BTK inhibitor that, and the third generation pertobrutinib, that is the third generation and reversible in and more selectivity in the BTK is also in treatment in this field. But in the ibrutinib is the first generation is the common use in the treatment of the CLL. What is the important? Because that the BTK inhibitor had the cardiovascular side effect in about that the hypertension. The hypertension is the most common, up to 80% that we can find in the ibrutinib. The second part choice is the atrial fibrillation. The higher rate will be met in the ibrutinib in the first generation of BTK inhibitor. The third is the breathing, and the fourth is the ventricular arrhythmia, and the fifth is the cancer therapy related cardiac dysfunction. And when we move to the review of about the BTK inhibitor, the ibrutinib and the next generation agent, you can find that in this topic that in the first generation the ibrutinib had a high cardiovascular risk factor. The atrial fibrillation can be found in the ibrutinib use is about 40%, and the hypertension is about 30%, and then the breathing. And why is that the bruton in the ibrutinib in the first generation of the BTK is more cardiovascular effect? It can cause that the less specific the less specific to the BTK receptor can that it has the off-target therapy to the other organ. It can cause that it can more severe cardiovascular risk factor. So when you look at in this selectivity, more selectivity will be have the low cardiovascular effect. So that's why mean that we should use to know about the BTK inhibitor and cardiovascular toxicity. And the higher risk for developing cardiovascular toxicity with ibrutinib. The first is that the older age, and the second is the male sex, and the significant valvular heart disease, especially primary valvular heart disease, can cause the high risk for developing the cardiovascular toxicity. And the pre-existing hypertension, when we use the ibrutinib, when the patient has the pre-existing hypertension, it can more risk to the worsening hypertension. The fifth is the presence of cardiovascular disease, especially coronary artery disease and heart failure may be the predisposing factor for the cardiovascular toxicity with ibrutinib. And the sixth is the left atrial chain from the EKG and the echocardiogram has the risk for the atrial fibrillation with the BTK inhibitor, especially ibrutinib. And how about guidelines say that when we assessment and monitoring atrial fibrillation during BTK inhibitor therapy, the echocardiogram, baseline echocardiography should done in the high risk patient who receive the BTK inhibitor, and the patient who develop atrial fibrillation during the BTK inhibitor should be performed in all patients who develop atrial fibrillation during BTK inhibitor. And how to screening the atrial fibrillation during this targeted therapy. The atrial fibrillation can be found during the patient receive the BTK inhibitor. So opportunistic screening may be that when the patient who come to the clinic, you should pause taking every visit when the patient comes to the clinic. And the next, when the patient has some symptoms, you should monitor about the ECG rhythm step. And then if the patient has a wearable device, such like as the Apple Watch or Garmin, we can use it in the opportunistic for screening for the atrial fibrillation in the patient who receive the BTK inhibitor. And then if the patient have the symptom, that palpitation, the further monitoring should be performed for screening the atrial fibrillation. And then we move to the management. In the pre-existing atrial fibrillation, patient who have the ibrutinib before the patient who have the ibrutinib and he or she had the pre-existing atrial fibrillation. He or she can receive the ibrutinib, but the patient should assess the risk of thromboembolic event using in the clinical risk score such as CHATWA score, because the anticoagulant and thromboembolic event is very important. And then when we use in the clinical risk score for evaluating the thromboembolic risk, in the case of the intermediate annual risk, we should modify. We should thought about the modify the risk of stroke, such as that the high atrial fibrillation burden, the persistent or permanent AF is very important. Obesity is the risk factor for the atrial fibrillation, and the metabolic syndrome, poor control, hypertension, hypertrophic cardiomyopathy, or who have the enlarged left atrium volume in the echocardiography may be that increase the risk of atrial fibrillation. And then about the anticoagulant in the patient who have AF before receiving the ibrutinib is very important, because that the drug interaction between the warfarin or the DOAC is very important. The DOAC will be preferred, but the factor 10A inhibitor such as rivaroxaban, edoxaban, or apixaban are preferred more than the dabigatran, because in the direct thrombin inhibitor such as dabigatran can be have a very serious drug interaction with the ibrutinib, so we should avoid the direct thrombin inhibitor. But in the patient who cannot pay for the DOAC, the warfarin and low molecular weight heparin can be administration, but you should monitor about the INR or factor 10A or the renal function monitoring, due to that the BTK inhibitor or ibrutinib can have higher bleeding risk. About the device and procedure, left atrial appendage in the AF ablation can be considered in some selected patients. But when we use the LA occluder, the patient who had the left atrium appendage occluder or closure should receive the antiplatelet after the procedure. The antiplatelet such as aspirin may be increase the risk of bleeding with ibrutinib. So we should just about the decision about the breathing risk and the thrombotic risk. And in the rate and rhythm control for the atrial fibrillation, the rate control beta blocker are preferred rate control agent, and you should avoid the non-dihydropyridine calcium channel blocker and digoxin. The non-dihydropyridine calcium channel blocker such as verapamil or diltiazem can have a serious drug interaction with the ibrutinib, and you should if you use need to use the non-dihydropyridine calcium channel blocker, you should reduce the dose of ibrutinib because that the drug interaction. And the rhythm control should be cautioned when we use the amiodarone or dronedarone, so that the temporary withholding the or reduce dose the ibrutinib should be considered when we use the high dose amiodarone or dronedarone. And in the patient who had the new onset or pre-existing AF occurring during the ibrutinib, the management in the new onset of atrial fibrillation should be concerned when we use the first that assess the hemodynamic stability and rule out the other reversible cause. And the rhythm control statistic is preferred in the hemodynamically unstable, and we prefer that the synchronized cardioversion is the first choice, and the other antiarrhythmic drugs such as amiodarone or dronedarone should be avoided. If we use it, you should reduce the ibrutinib. And then the rate control in the hemodynamically stable should we should avoid the non-dihydropyridine calcium channel blocker, and we should use the beta blocker. Is safe for the patient who receive the BTK inhibitor, especially ibrutinib. And if rate control is not success, you can decide to discuss with the oncologist about to replace the ibrutinib with the second or third generation, which have the less side effect of atrial fibrillation and have more less drug interaction with the other drug. So this is in the management of atrial fibrillation and drug interaction who receive the BTK inhibitor, especially ibrutinib. Diltiazem and verapamil have the major side effect with the ibrutinib. Also had the amiodarone and dronedarone and dabigatran. So we should avoid the diltiazem or the verapamil, amiodarone and the dabigatran, and we change to the factor 10A inhibitor if we need anticoagulant for treat the atrial fibrillation. And then we move to the next in the hypertension and cancer therapy. In hypertension in the cancer treatment increase the risk of cardiovascular outcome, especially in the anti-cancer therapy. In patients who had the hypertension, when we can have the cardiotoxicity, nephrotoxicity, and vascular toxicity, and increase the cardiovascular disease and mortality. But the incidence and mechanism of hypertension in cancer therapy, you can see that the incidence of Butan tyrosine kinase inhibitor had the highest increased risk of the hypertension, about 71%. And the mechanism of hypertension can be caused by the vascular stiffness, angiogenesis, decreased angiogenesis, and increased sympathetic outflow. In the study that the hypertension and incidence of the cardiovascular event in the ibrutinib initiation. When we start the month, you can see that the month after the ibrutinib initiation, the blood pressure that will increase in the systolic blood pressure, the diastolic blood pressure, and also mean arterial blood pressure after the ibrutinib treatment. And then that the cumulative incidence of new hypertension has increased from when the ibrutinib is start, and when the patient who had the hypertension, the worsened hypertension is also increased the incidence. So we can conclude that the patient who receive the ibrutinib, the hypertension may have the new onset or maybe the worsened hypertension. So the guideline tell us about the baseline risk assessment and monitor blood pressure during BTK inhibitor therapy. Blood pressure measurement should be performed in all the patient who had the BTK inhibitor in every clinic visit. And then if the patient have the home blood pressure monitoring, the patient should monitor their self blood pressure at home during the first 3 months and every month after they receive the BTK inhibitor for monitoring about the new onset hypertension or the worsened hypertension. And hypertension treatment in the BTK inhibitor that we should be concerned at first, that should be concerned the patient profile that about how the active malignancy and in the staging of the malignancy. And the guideline told us about that the systolic blood pressure who more than 160, you should treat all the patient profile that about the hypertension in all the patient profile. But in the patient who had the cancer survival or curable cancer or had the metastatic cancer is with prognosis more than 3 years, you should treat when the blood pressure is over than 140 in the systolic blood pressure. So that is why treatment and target blood pressure is very important in the cancer patient. And how should be management in the pre-existing hypertension? In about antihypertensive drug therapy, we prefer the combination therapy according to the hypertension guidelines, and the beta blocker and renin-angiotensin receptor blockade can be used. But you should the dihydropyridine calcium channel blocker such as amlodipine or manidipine is relatively safe and should avoid the non-dihydropyridine calcium channel blocker. And when the patient had the uncontrolled hypertension or may have the worsened hypertension, we can, if we can switch the ibrutinib to the second generation BTK or third generation reversible BTK is safe for control hypertension. And then you should aggressive modify risk factor and lifestyle modification in the patient who had the pre-existing hypertension before receive the BTK inhibitor. How should the management about the new onset or worsening pre-existing hypertension? The antihypertensive drug treatment is very benefit, and we should use the combination therapy, and you should avoid non-dihydropyridine calcium channel blocker, and dihydropyridine calcium channel blocker can be the second line drug therapy in patient who had uncontrolled blood pressure and is safe for use in the BTK inhibitor patient. And then we should move to the last topic about the bleeding risk. And BTK inhibitor and the bleeding risk factor is very important. The BTK associated antiplatelet mechanism has the 5 mechanisms about the target of platelet aggregation. The first it inhibit in the signal of the platelet collagen receptor glycoprotein 6, and then the second is the inhibit to the tyrosine kinase linked to the von Willebrand factor, and the third is the induced shedding of alpha 2b beta 3 is a key role of in the platelet adhesion and aggregation, and the fourth is the inhibit about the C-tylectin-like receptor 2 in the platelet aggregation, and then the fifth is the inhibition of TEC kinase. All of this is about the platelet adhesion and aggregation. So when we use the BTK inhibitor, we block the mechanism of platelet aggregation. So bleeding risk is very high and increased. And in this, the meta-analysis show that the overall bleeding in different treatment in the setting of the patient who receive ibrutinib, we can see that the risk of the bleeding risk is increased about two times from the patient who did not receive the ibrutinib. And in the patient who had acalabrutinib in the second generation of BTK inhibitor is also increased risk of bleeding in about 3 times more than the patient who cannot receive the acalabrutinib. So in the BTK inhibitor and the bleeding risk, the increased risk of bleeding is high when we use with the antiplatelet agent, and then dual antiplatelet should be avoided if the patient have received the BTK inhibitor, especially ibrutinib. And if antiplatelet therapy, it is very important to treatment the other disease such as the coronary artery disease. We prefer use the P2Y12 inhibitor for reduce risk the bleeding, and we can should we should close monitoring about this bleeding. And about when we have the BTK inhibitor and bleeding management, the patient who have undergo other surgery or the procedure that can increase risk of bleeding, when we use the BTK inhibitor and antiplatelet, you should avoid, you should stop the ibrutinib 3 days for minor procedure and 7 days for major procedure to minimize risk of bleeding. And the patient who have the bleeding during the BTK inhibitor, you should hold BTK inhibitor until the bleeding is resolved. And in the severe case of bleeding, we may need the platelet transfusion. Even if the platelet is in the normal range, but the platelet function is quite bad due to the BTK inhibitor, we may require about the platelet transfusion to stabilize the function of the platelet. And then this is the consensus, the cardiovascular toxicity in the targeted anti-cancer therapy of the ACC that launched in about the last year. And then we can use this for conclude about the BTK inhibitor and other the targeted therapy for cancer patient to avoid about and management about the cardiovascular risk factor. So in the conclusion about the BTK inhibitor and cardiovascular toxicity, in the hypertension, atrial fibrillation, and bleeding is the most common cardiovascular toxicity of the BTK inhibitor. But BTK selectivity is greater is associated with the cardiovascular toxicity, and the drug interaction may be concerned in the atrial fibrillation management. Factor 10A inhibitor is preferred, and you should avoid the direct thrombin inhibitor, non-dihydroperoxine, calcium channel blocker, and digoxin. The third point is that hypertension is under-recognized and progressive during ibrutinib therapy. And the fourth point that BTK inhibitor combination with the antiplatelet may increase the bleeding risk. So if the antiplatelet therapy is required, we prefer P2Y12 inhibitor for and post monitoring for the management in the BTK inhibitor combined with the antiplatelet. Okay, thank you.
Thank you, Dr. Satalam. Okay, so I think thank you for that. It's a very comprehensive summary, and this is definitely a therapy that for the general cardiologist we're probably a little bit less exposed to compared to the breast cancers, anthracyclines, trastuzumab. So I think, but nevertheless, the side effects are very cardiology pertinent because it is hypertension and it is atrial fibrillation. So I think for those who are not too familiar in the audience with cardio-oncology, I think the main thing is with the BTK, the classic textbook side effect is that of atrial fibrillation. So, but Dr. Sethla, I just wanted to ask, so, with AF, we've talked about the risk of AF, we've talked about the increased risk of bleeding. So, I mean, it's probably going to be the next question, a common question. So, how does that affect your decision for anticoagulation, knowing that they are at risk of AF and yet knowing that they're at increased risk of bleeding? I mean, as a practical kind of tip, are there any considerations for what we should initiate on? Are there any, I don't know, different scoring systems that we might want to use? I don't know. What's your practical tip on how to approach this?
Thank you for your question. But in my hospital, I think we should discuss with the oncologist and the patient about the bleeding risk and the thromboembolic risk. I think it's very important. If the bleeding risk is lower than the thromboembolic risk, so we will discuss in the multidisciplinary team with the hematologist, oncologist, and the patient that in this patient have the higher rate of thromboembolic risk. So we decide to use the anticoagulant for the atrial fibrillation treatment. But in the atrial fibrillation treatment, we know that we prefer the DOAC more than warfarin. In the cancer patient, when we review to the topic, I think that the DOAC is safe more than the warfarin. But in the DOAC, I think factor 10A inhibitor is safe more than the antithrombin in the dabigatran. I think when we discuss with the oncologist, hematologist, and the patient, and that thromboembolic risk is higher, so we prefer to use the anti-10A inhibitor in the protect in the anti-thrombotic event in the cancer patient.
Yeah, no, I think those are great tips. And I think just one other question. So so I'm an interventional cardiologist and a cardio-oncologist. So I do PCI, which is not like most of you who are all imagers and more clever people here. But I'm just thinking, so in terms of, let's say, with this AF, because a lot of my EP colleagues are all into burning AF now, there's more indications to burn AF. I'm just curious, in your experience, have you seen, anyone burning the AF prophylactically before starting anyone on TK on these inhibitors? And have you seen like any risk of recurrence or any knowledge of this in the literature? Because I'm just curious, a lot of people are very aggressive with burning things now. So I don't know if that helps with reducing the AF problem.
I understand with you that I am not the EP, but I think in my country, AF ablation is difficult. It's very difficult. So I think that burning AF before the ibrutinib, I think it's a big problem because that when you use the AF ablation, and then I think that if the patient have the risk for the AF, that the older age or the right left atrial volume or left atrial size, it may be the risk of recurrent AF after use the ibrutinib. I think if the patient have not the indication for the AF ablation, I think we should avoid to use overuse about the AF ablation.
I only mentioned this because I saw you mention ablation as one of the options for the treatment of AF in the slides there. But no, I fully agree with you. Yeah. Thank you. No, I think that was a great talk. And I thank you for that then. I don't know if anyone has any questions. No problem. Thank you.
Thank you.
All right, then maybe Dr. Chang, we can carry on there.
Sure. Okay, so okay, I'm going to introduce the next speaker and also my co-chair, Dr. Koo, and he is a consultant cardiologist in National University Heart Center Singapore, and he's also the vice president of the ICON Singapore. So today his topic is about the risk factors, diagnosis, and the treatment of cardiovascular adverse effects with VEGF inhibitors, hypertension, venous thrombosis. So please, Dr. Koo.
Thank you. Let's go slideshow. Okay. So afternoon, everyone. So I'm Chiang, I'm Chris, and I'm from Singapore. And I think today the topic that I was given was that we're going to talk about risk factors, diagnosis, and treatment of the bad cardiovascular stuff in VEGF inhibitors. So we're going to talk primarily about hypertension and venous thromboembolism. Okay, so I think it's always nice to share some cases first, and we're going to go with a spectrum of cases here. So the first case that we have here is a 65-year-old gentleman. So I've seen him in the clinic for a few years now. His BMI is about 21. He doesn't smoke. He's got hypertension, not too bad. So it's controlled on amlodipine, just 5 milligrams daily, and he's got a bit of lipids. So he's seen me before in the past for some atypical chest pain, and he's had a CT scan done a few years ago, and it's really non-obstructive coronary artery disease that you can see. But along the way, when I started seeing him, unfortunately, he got diagnosed with metastatic hepatocellular carcinoma. So he got started on atezolizumab as well as bevacizumab, the latter being that mainly of VEGF inhibition. So then what happens is that we know that, or at least now you will know, hopefully, that the VEGF inhibitors have a risk of hypertension. So we start monitoring his blood pressure, and thankfully this is a patient who's a little bit, more clever and more enthusiastic about his health, because sometimes we get patients who are not so enthusiastic about their own health. So I tell him about the risk of blood pressure going up, and he starts to monitor his blood pressure at home. So within about 1 to 2 weeks of starting these medications, his blood pressure goes up, 140, 150 systolic. And then the good thing is that he actually is able to email me. So he emails me, so he gets in touch with me about his readings. He doesn't come to the hospital. And so I tell him, okay, bump up the amlodipine to 5 to about 10 milligrams. 1 to 2 weeks later, and this is about 3 weeks from initiation of the therapy, his blood pressure has crept up a little bit more again. So it's now 150, 160, systolic blood pressure at home. It's still high. So because of that, I kept on the amlodipine of 10, and I started him on an ARB, so valsartan 80 milligrams BD. And with that, actually, his blood pressure comes down. So it's about 120 to 140 systolic. And that's about nearly a month from initiation of his VEGF therapy. And I think this is just a very simple case to illustrate what happens with the kind of blood pressure response that we get when you start with VEGF, namely that it starts usually quite soon after the initiation of VEGF therapy. And I think that you need to probably monitor them closely, at least at the start. And it's always helpful having a patient who's able to feed this back with you. So this is a pretty run-of-the-mill standard kind of patient that you get in someone who has VEGF therapy. Just note about the hypertension that it comes early. Now, this is a different spectrum. So this actually just happened last month, and I thought it was quite interesting to share. So it's a 70-year-old lady who, again, is, not too fat, not too skinny. She's got hyperlipidemia, and she's got a stroke before, now nearly about 10 years ago. She had some thrombolysis before, and actually she's got no neurological deficits. So she's completely well. She walks around, she's fine. So she's got a long history of this cancer. Now, she's not known to us at this point. She's been living in the oncology world. None of us cardiologists have ever seen her. So she's got metastatic sigmoid colon cancer and has gone to the bilateral ovaries at the point of diagnosis. So that's the Krukenberg tumor. And this was diagnosed about 8 years ago now. Multiple lines of chemotherapy. I'm not going to go really in depth into the cancer therapy, but she's had Xelox, and then I think she progressed. She had FOLFIRI and panitumumab at the second line. And throughout all these kind of adjuvant therapies, at some point she has her anterior resection to resect the primary tumors. Along the way, she gets lung metastases, which they chopped it out. Along the way, she gets liver mets, which they've chopped it out as well. And she also had some form of faint recurrence in the cecum, and they chopped that out as well. So they've actually been having a lot of operations in this lady. Third line wise, she gets Lonsurf and bevacizumab. So that's when the VEGF inhibition comes in. And then along the way, I think the response isn't so good. So now they've started on this fourth line fruquintinib, which is a newer sort of kind of VEGF, and that's an oral tablet. So that's where we're at now. And again, she's living in the oncology world. So the oncologist starts her on fruquintinib, 5 milligrams daily. And from what I understand, that's probably one of the higher doses, with the knowledge that the BP can potentially go up. So she starts the patient on 5 milligrams daily, and this is at the start of January. Blood pressure in the clinic at that point, without the medicines, was about 117 systolic. And the oncologist, on her own accord, started losartan 25 milligrams daily. So that's a small dose, and that's because I think she's still worried about the blood pressure going up at this point. So rightfully, the oncologist is worried, and the oncologist brings the patient back to review in 2 weeks later. And at 2 weeks later, with the low dose of losartan, the fruquintinib at 5 milligrams daily, her blood pressure is about 162. So it sounds like things are great. Now, 2 weeks later, which is actually a month later from the initiation of therapy, so she comes to the emergency department at this point. Now she's dizzy and her blood pressure is sky high now. So her blood pressure has gone up to 170 to 100 to 200 systolic. The diastolic is ridiculously high at 100 to 160. Clinically, she's confused a little. She has difficulties finding the right words at times to talk about things. Neurologically, there was some documentation that she had a right gaze deviation, but otherwise there was no other focal kind of neurological deficits, no weakness to suggest any kind of stroke per se. But notably, she was very unsteady on standing. So I think in the emergency department, as usual, they would send her for a CT brain. Not quite sure if you can see the CT scan well on Zoom, but what it shows here on the CT brain is that there's no acute bleed, but you might appreciate that towards the bilateral occipital lobes, that there's a little bit of more dense kind of appearance, suggestive and reported by the radiologist as edema in the occipital lobes bilaterally. So they go for an MRI, and what the MRI shows is that bilaterally in the occipital lobes as well, there's an increased signal to T2 flare in the occipital lobes as well. So I think with this was consistent with the blood pressure being high, the appearance being that of PRES, so that's posterior reversible encephalopathy syndrome, and that's usually associated with high blood pressure. So this lady was diagnosed with PRES, and that's of course one extreme spectrum of high blood pressure, and that's what happens, if the blood pressure doesn't get well controlled at the very end. So she was managed acutely with IV labetalol, and pretty soon, within 1 to 2 days, the blood pressure came down. And this is when we got involved as cardio-oncologists, when all these started happening. Of note as well, she had a concurrent MAHA, or that's microangiopathic hemolytic anemia. And that was on the side, the anemia. There was some suggestion that the HB came down, the hemoglobin came down. There was thrombocytopenia of platelets in the 30s, a low heptoglobin, high bilirubin, high LDH, negative Coombs. So this was a by the way kind of thing, probably related to this whole thing as well. Along the way, we put her on amlodipine 10 and losartan 75. Blood pressure in the ward was about 100 to 120. It came down pretty soon. About within a week, she was pretty comfortable on all this. Diastolic was about 60 to 70s, and neurologically, she recovered completely. But I wanted to use this case to show you the other extreme of VEGF in a hypertensive kind of crisis, where you can actually get something really bad. And then I think we discussed, and of course, the oncologist didn't want to re-challenge her on this VEGF inhibition subsequently, given the severe toxicity. So they're going to find a different line of therapy for her. So I went on to just look around for a case report, and actually there are quite a few cases. Few in the sense there's only 2. And this is one from China, which I thought was quite interesting. So what you have here is a 44-year-old lady who actually was with metastatic colon cancer. What you see on the top of A, B, C panels in the top 3 at the top is that she was first started on fruquintinib at a slightly lower dose of 4 milligrams daily. So that was, I think, probably they're trying to start her on a lower dose, and they thought she tolerated it well. So they bumped her up to 5 milligrams daily. And after they increased it to 5 milligrams daily, her blood pressure went up and she presented with seizures. And you can see on the MRI scans on the top that it's the same kind of appearance with the high intensities in the bilateral occipital lobes there. Now, the interesting thing is that, so what they did was they gave nifedipine, mannitol, steroids to try and reduce the edema. And you'll see in GHI panels there that actually that sort of kind of signal intensity has sort of decreased a little. And what they tried, which I found was interesting, that 1 month later, they actually tried to re-challenge her on the low dose of fruquintinib, so 4 milligrams, which she tolerated previously. But yet, within 3 days, when they actually did the MRI, she didn't have symptoms, but they're just very cautious. But within 3 days of repeating the MRI, these kind of signal changes appeared again, so they decided not to do this again. But I just thought it was interesting that within, when they re-challenged this, you could see these kind of effects happening again in this lady. So those are the spectrums, but I think the message of VEG inhibition kind of hypertension is that it's very common. So as you can see from the ESC guidelines here, that there are different types of VEG inhibition. They classify that as the monoclonal antibodies and the TKIs, or the tyrosine kinase inhibitors. And you see that there are all sorts of side effects, but the one with the biggest circles and the one with the reddest circles, which means that they are most common, of more than 10% incidence, is that of hypertension. So hypertension is very common in this group here. Now, this is an old study, but what I'm trying to show in this study is that some VEG therapies actually cause higher BP than the others. So you'll see on the left here that study numbers may not be big in some, 49 patients to about 900, but what you're just going to get a flavor here is that the incidence of blood pressure can range from 10 to 70%. And on the column on the right of this red box here, which is the grade of severe hypertension, defined as a grade more than 3, you'll see that it goes up to even 33% in certain types of VEGF inhibition. And in another study, which is a little bit more recent, so this was just looking at the TKIs itself for the VEG inhibition, that certain TKIs like axitinib in the purple bar seem to be maybe have a more hypertensive kind of effect than others like the yellow bar, cabozantinib or sorafenib in the red. Just signs that, not all of them are the same. Some are probably more at risk of hypertension than the other. Again, we always have all these kind of mechanisms kind of slides, but I think the main thing I just want to highlight is that the hypertension from VEG at this point is thought to be various factors, multifactorial. We love that word, but anyway, it's mainly low nitrate oxide because nitric oxide helps to vasodilate. It increases endothelin, which is a vasoconstrictor. It creates more reactive oxygen species, and that causes more oxidative stress, higher BP. And it causes rarefaction, which is some form of reduction in terms of the microvascular capillaries. And therefore, with the reduction in the microvascular bed, you get an increased overall resistance, and that leads to a higher blood pressure. There's some other side effects related down the nephrotoxic kind of pathways. But anyway, these are the rough pathways. But why I'm mentioning this pathway here is because we were talking about the VEGF being different types of therapies. So if you look at the monoclonal antibodies, and the most common one that people will know is the old agent bevacizumab. Now, this works on attacking the VEGF directly or the receptors itself. And that is a little bit more targeted in a way, and that's why the hypertensive effects are probably about 20 to 30%. Your bad hypertension can be around 15%. Now, compare that if you use the TKIs, which block an intracellular kind of all types of different kinase activities. Now, that causes a much higher risk of hypertension, nearly even about 70%, and even the grade 3 hypertension incidence is a lot higher. So again, a bit of difference within VEGF therapy, although it's all really hypertension. So in summary, VEGF inhibition-related hypertension is really dose-dependent. It occurs early, within hours to days. It's usually reversible upon discontinuation. And the other thing is that there's this idea that it can be associated with cancer therapy efficacy, although I think I'll leave that as a question mark because it's not really set in stone. It's still a bit more of an association than anything. But it's dose-dependent, occurs early, and it's usually reversible. So I think we've seen these kind of slides, how you monitor and treat the hypertension. But I just want to highlight the idea here that if it's more than 160 systolic, then you should really think about starting dual kind of therapy, and that's ACE as well as your calcium channel blockers. And this guideline, which is more recent, I think Dr. Satterlal was showing as well, is that if your VEGF inhibition causes the BP to go more than 180 systolic, then you might want to hold it off until the blood pressure comes down below 160. It suggests getting for a target of 130 to 80, or some other older guidelines may suggest 140 over 90. But I think what this sort of diagram shows as well is that your first line should be an ACE ARB, and then the second line would be your calcium channel blockers. Again, just like with the Bruton TKIs, the idea is that you should consider or you should advise your patient to monitor the blood pressure frequently, especially during the first cycle at home. And every time when you increase the inhibition dose, then actually they should be continuing to measure the blood pressure as well, maybe 2 to 3 weeks after thereabouts. All right, so that's blood pressure. Now we're just going to move quickly to the VTE. So this is a bit less interesting. So it's a 75-year-old guy, hypertension, hyperlipidemia, metastatic colon carcinoma, first-line FOLFOX and bevacizumab again. So bevacizumab being the VEGF therapy. So presents with acute exertional dyspnea. Saturations are about 90, 91, 92 on room air. Heart rate is slightly tachycardic, 100. Blood pressure is still holding, 112 to 70. Troponin is high. BNP is high. So I think most people would think that this is a PE. So the patient went for a CT scan. What you see here is that in the CTPA here, you would see filling defects in both the main branches of your pulmonary artery in the left and the right. So that's where the contrast dropout is there in both sides here. Not quite a saddle PE, but nevertheless bilateral PEs in the main branches. So this is not my case. And I think, in cardiology, there are all sorts of hungry people around. So this patient was referred to the PERT team, and unfortunately or fortunately, I don't know, he went for catheter-directed thrombo aspiration. So I know there's the latest PE guidelines, and I think we would find that this is probably not something that I would do first line as well. But I just wanted to show this that, it's funny how people always like to, show off their results with this kind of standard photo here that they have. But what I found interesting is that the number of clots on the left side, it's not that many. And if you can actually scrutinize the hemodynamics pre and post, there's actually no real difference in terms of the hemodynamics. So your blood pressure has been the same, your sets are the same, your mean pulmonary artery pressures actually haven't changed from 17 to 20. But anyway, I digress. So this patient went for sucking, and then was started on low molecular weight heparin. And then I think, there's a bit of a discussion, does bevacizumab cause an increased risk of VTE? Are we safe to continue it? And I think we just continued the patient on bevacizumab as well. So VTE, I think this is just a generic kind of slide for everyone, not specific to the VEGF inhibition. But what you would do is you assess your thromboembolic risk. So in this gray box here, you would assess the thromboembolic risk, you assess the bleeding risk, you assess the drug kind of interactions, and you would get the patient's preference. I think more kind of actionable kind of ideas would be determine whether the patient is of very high bleeding risk. So that's defined in the black box on the right there. So any active bleeding within a month, any intracranial lesions, or any ridiculously low platelet count less than 25. At that point, you might want to discuss whether you anticoagulate or not, although the guidelines suggest that you may not want to anticoagulate. Now, and then you may want to choose conditions where you would favor low molecular weight heparin over the DOACs, and that would be if there's a GU cancer, GI cancer, bad renal function, DOAC interactions, as well as a moderate thrombocytopenia. And I think because this patient had an unoperated kind of GI cancer, then we went down the Claxane route. Again, just like with the BP, so VEGF inhibition, not all of them have the same kind of increased risk for VTE. What I'm just showing in this kind of old study as well is that the bevacizumab actually was reported to have a high incidence of VTE. You can look at it 12% with a relative risk of about 1.3. And if you look at the remaining kind of VEGF therapies bracket with the TKIs there, you will see that the relative risk is a little bit more equivocal there. Some even saying not applicable because, it's not really an increased signal of VTE. So I think with the TKIs plus minus, but I think with the monoclonal antibodies, especially bevacizumab, there is a slightly increased risk of VTE in these patients. And just like the Bruton's tyrosine kinase inhibitors, bevacizumab also increases the risk of VTE and bleeding. What you see in here is that it increases the risk of VTE about 1.3, and as well as the bleeding, it can go up to 2 to a relative risk of 3. There are, of course, risks with the arterial thrombosis bit, but I think that's not a topic for today. And the last thing is just, I think a lot of times as cardio-oncologists, when people have an adverse event, the one of the questions that oncologists will ask you is, can they continue the therapy or not? So this is not a great study. This is a retrospective kind of study of about 160 patients. And what they actually looked at was they looked at all patients with bevacizumab who actually had some form of venous thrombotic event. Their population here was that about 50% of them had a PE, and 40% of them actually had bilateral PEs. So maybe pretty substantial. And what they actually did was most of them, sorry, I digress. And then they looked at these patients. Some of them continued bevacizumab, and some of them discontinued bevacizumab. Again, retrospective, so a lot of confoundings, but it just gives you an idea. So they treated both of them on low molecular weight heparin. But what just this study was trying to show was that regardless whether you continued them on bevacizumab or whether you stopped the bevacizumab, the incidence of VTE recurrence or the incidence of bleeding between whether you stopped or you continued the VEGF inhibition didn't seem to differ. Of course, this is a retrospective study with a lot of limitations. But really, I think in conclusion, so I think the first thing I just want to highlight is that VEGF inhibition has a high incidence of hypertension. The main take-home point is monitor it early and treat it early. In terms of VTE, the risk of VEGF inhibition on VTE is a little bit more modest. It's higher with monoclonals than TKIs, but I think really it doesn't really change the way we manage VTE in these patients. And I think the most important thing is that as cardio-oncologists, the role is really not to stop cancer therapy. A lot of time, oncologists get scared with everything. And I think our main aim is really to try and keep the patients safely on it. So I think a lot of things that we do is really trying to calm the oncologist down most of the time and tell them to carry on with their therapy. All right, but that's it. Thank you very much.
Thank you so much. It's really nice talk, and actually, I really appreciated the beautiful big cases. Actually, learned a lot. So, actually, I have several questions. Like the first one is that you mentioned about oncologist view. So, actually, I truly heard a lot about oncologists who would suggest, if the blood pressure is going high, which means the VEGF inhibitor is more effective to treat the cancer. So it's kind of like a dilemma, which means now sometimes you ignore about the blood pressure. So just want to know your opinions or like how to educate the patient, or sometimes we don't want to discontinue the treatment. But how could we work together with the oncologist? Want to know your opinions. Thank you.
I think that's a great question. I think the main thing is that the idea of efficacy and hypertension, I think ultimately is still more of an association rather than something that we know for certain. But I think we most of the time hypertension is sort of it doesn't come across as something so terrible. So most of the cases are like the first guy, blood pressure goes up, they feel fine. If you don't check, you don't know, nobody knows, everyone's happy. But I think, every now and then you get bitten by someone who gets this awful kind of hypertensive kind of problems, be it like heart failure, be it like a bleed in the brain, and rarely like press in this case. So I think at least from my end, I think I would still push forth with bringing down the blood pressure. And I think a lot of times the oncologists, I think, are the ones that actually, so more often than not, I think at least in our center here, the referrals come from the oncologists. So of course, the problem is that we don't see the patients that the oncologists are not worried about, right? So there's probably a lot of them running out with bad blood pressure. But I think those that come to see us, I think they are well primed, and at least the oncologist is more primed, for cooperation and trying to bring down the BP. So I think the only way, like you rightly said, is to just get buy-in from the oncologist, every now and then they'll see a bad case and they get panicked, and then I think that's when they realize that you really have to keep an eye on this.
Yeah, truly agree. Sometimes, more complications is always better. Yeah. So, and the second question is about the VTE. So I think the cancer associated thrombosis is always a tough question. So, would you agree that possibly we can do like some screening for like a high risk populations as how we treat the patient with cardiomyopathy? So, you think that because VEGF inhibitors not only but the other cancer treatment also cause like the endothelial dysfunctions and the VTE. So would you think that screening will be a good idea, or some trials said like a prophylactic, just NOAC or anticoagulations would be good for these patients? So just want to know your opinions about that.
Okay, so I think scientifically, I think there are people who have looked at prophylactic kind of, anticoagulation, especially in the ambulatory kind of cancer patients. You've got different scoring systems, Corona kind of system, Corona score, blah, blah. And of course, it's nice whenever people do more research that hopefully we can sort of individualize this, because I think a lot of problems as we find is that, like people have mentioned before, that there's no one size that fits all for everyone. Now, personally, my own opinion, and this may not be everyone's opinion, is that I try to interfere the less the possible. And I think you interfere with fewer medications the possible, because these patients have a lot of medications already. And even just like the breast cancer patients, when you try to start them on something, even though their EF is a bit marginally low, I'm sure half of the time the patients are having some form of resistance to even starting medications in that sense. So at least my own practice, and it may not be everyone's practice, is that I generally try not to put too many prophylactic kind of medicines on. So of course, hopefully the end goal will be if someone can actually do some of personalized kind of, VTE prediction, then we can predict it better. But I think at this point, yeah, I'm still more cautious in that sense.
We agree. So I think we are running perfectly about the time. So okay. So now is the time to close this section. I think that everybody learns a lot. So I just invite my co-chair again to close this section. Thank you.
Well, thank you, everyone. So I think that the best things about the APSC kind of meetings are that you get to hear people from all sorts of different parts of the countries in the region. And I think today we've heard from a lot of different speakers. I think we've heard from Dr. Adriana regarding the importance of cardiotoxicity prevention, especially in the anthracycline patients. So that's important because that's a very big bulk of your referrals. as well as we heard from Kohei from Japan about what to do in the trastuzumab population. And that's another big bulk of referrals that you get in cardio-oncologies. So these two are the big ones that you get. And I think we've learned about how to risk stratify them, monitor, and treat them. We've also heard from Dr. Hung about immune checkpoint inhibition, myocarditis. Now, that is not as common as the breast problem, but when it happens, it's very nasty. So I think it's something that we need to have a high awareness and be alert in terms of treating it. And of course, we heard from Dr. Settler about the Bruton TKIs and AF, and that's very pertinent in terms of cardiology because once they get AF, the oncologist is going to refer to you. And I think that's something specific and useful for us to know as a cardiologist on how to manage it. And I think lastly, we heard a bit about VEGF inhibition, blood pressure, as well as VTE. So just monitor it early and just be aware that we have to keep an eye on these patients and support them through their journey. And I think that's all I have. Anything to say, Dr. Chang?
Oh, actually, it's perfect, and thanks for the summary. So just thank everybody's attention, and they're also look forward to the next section about the cardio-oncology in here. Thank you. Okay.